I'd like to bring back Kelly Gillis, who's going to give us an update, a LHIN update. For those of you who don't know Kelly, Kelly's been a Senior Director of Planning, Integration and Community Engagement with the South West LHIN for the past 5.5 years. Kelly has more than 12 years of leadership experience in the healthcare sector, focusing on strategic planning and system integration within southwestern Ontario. Prior to joining the LHIN, Kelly worked for London Hospitals as the Director of Medical Affairs, and she's also worked in the systems integration. She's also as the systems integration leader for the Huron-Perth Hospitals Partnership, and as a senior health planner with the Huron-Perth and Thames Valley District Health Councils. Prior to joining the District Health Council system, Kelly worked in the long-term care, mental health, and addiction sectors. Kelly?
Thanks, Bob, and we'll go through this fairly quickly so that we do have a number of things to work through. So just to give a little bit more context for the evening, we are really focusing, as I said, on access to care, and what that means will become clearer as the evening unfolds. We'll be giving you some context around that. Before going there, we're going to talk a little bit about the current environment with local health integration networks across the province, and then move into a video presentation that we've created to communicate around our access to care initiative. So that will really set the tone for the evening and help to convey what access to care represents from a South West LHIN perspective. And then myself and Donna are actually going to talk to you a little bit more specifically about how we're implementing this work across the Southwest and the progress that's already been made. And then we're going to ask you to engage in some discussions at your table. And so just to prep you for that, we really do tonight want to hear your input about access to care. And so we will have some discussion questions for you to respond to in those small group discussions, with the objective of then engaging our panel presenters, our panel rather, I should say, in discussion about access to care. So as you learn more this evening about the Access to Care initiative, we're going to be asking you to identify what challenges you see, what opportunities you see, and any questions of clarification that you might have and that you want to talk to the panel about. So I'll just give you that heads up on the to-do that will unfold as we move through the evening. So just a little bit briefly on the current environment that LHINs are working in, and certainly everybody I'm sure is well aware we now have a Liberal minority government, and so what that means for healthcare going forward I think yet remains to be seen, but we know that there will be active discussions over the next number of months around the healthcare context here in Ontario. We have a new Minister of Health on one level, but it is the same Minister of Health, and so again we're pleased that Deb Matthews is in that role. She has been very supportive of the LHINs and the work that we're doing across the province, and so we continue to see the opportunity for improvement within our healthcare system, and so we have lots of opportunities, lots of challenges still ahead of us, and so we're quite committed as a LHIN here in the Southwest, but across the province, all LHINs, trying to move forward the work that we can to improve our healthcare system. So the throne speech, we're still waiting for to hear what is moving forward. Certainly the last throne speech, we know there was a delay in the review of the LHIN structure, and that's yet to come. So lots more conversations in Ontario about the Made in Ontario approach to regionalization and how that moves forward in the next number of months. While all that talk goes on about how healthcare is structured and how we're moving forward, we do know there's significant provincial fiscal pressures that we're working within, and so challenges around fiscal constraint does impact the healthcare system, and so that's sort of an overriding piece as we look at where we're headed over the next number of months and years here in Ontario. And again, really looking at what are those improvement opportunities despite the financial challenges that we face. And so those are the pieces that we reflect on as we do our work in the Southwest and across the province as local health integration networks. As we move forward, the different initiatives that we're working on, physician engagement is always key, and so Eric referenced earlier this being, I think, our 5th session here in Grey Bruce. We have a number of ways in which we look to engage physicians in the work that we do as a healthcare system here in the Southwest. So want to update on the advancements, particularly with respect to the Southwest Primary Care Network. And that's actually co-chaired now by Dr. Rob Annis, who was mentioned earlier, and Dr. Gord Schachter. This is a group that started last year, actually, focused around cancer care. And Rob Annis brought together a number of primary care representatives across the Southwest to engage with him around cancer care issues, particularly related to his role as primary care lead in colorectal screening. And that's evolved now to be a network focused more broadly around primary care engagement. The LHIN has supported it, the OMA has supported it, and the London Regional Cancer Program to take on a role of engaging physicians more broadly across the Southwest. And so local representatives from across the LHIN have been identified to be a part of that network, and they're tasked with reaching out to physicians in their local communities on key issues of importance to primary care. So that's a group we're going to continue to work with from a physician engagement perspective. We will continue to do these sessions with the OMA. We think it is a good opportunity to get out and dialogue with physicians. And so we appreciate the support of the OMA and partnering with Leo to move these forward. And we do now keep that on our annual schedule of physician engagement activities. And we hope that they are value add. So again, appreciated Eric's comments. We had very positive feedback from our last session, which was focused on quality. And I know a number of you were in attendance at that event as well. So hopefully you find tonight is engaging. We also really look to engage physicians around project or topic specific work. The example on here is the SPIRE implementation, but there's many initiatives that we work on where we bring physicians together through focus groups. For some projects we have physician leads that are actually identified that work with us directly on a particular project. So we look for multiple ways to engage, and some of you may have been involved in some of those initiatives in the past as well. And then we are continuing to focus on the opportunity that we benefit when there's leads assigned to particular portfolios. So you'll know that Dr. Mike Sharp has been the critical care lead for a number of years in the LHIN. Most recently, Dr. John Dreyer was appointed as our new ED physician lead. And across the province, there's a recruitment process underway right now for primary care leads. Just a show of hands, are people aware of that process? Is anybody aware of that process? Couple of people. So this is a position that's been agreed upon now for each of the 14 LHINs to have a primary care lead, and actually the request for those leads, the request for proposals process, actually, because it's looked at as a consulting arrangement, has actually been extended, and there's information on our website. So if there's anybody here from a primary care perspective that would be interested, or you know colleagues that are, we're actually still seeking a primary care lead for our LHIN, and each of the LHINs across the province is going through that process. It is a consulting procurement process, so it's a bit of an unusual process to engage physicians in. It's the requirement provincially, and this will be a paid position across the LHIN to provide leadership around primary care. So I'll just put that bug in your ear, because we are actively looking for our primary care lead right now, and that process is underway, as I said, across the province. So another opportunity we feel to strengthen engagement with primary care from a LHIN perspective. So then moving on to access to care and what tonight's agenda is all about. Access to care is really a province-wide strategy. We're really looking at how we support the movement of individuals out of acute care settings to the right care at the right time in the right place, and making sure that that transition happens as smoothly and safely as possible. It is a strategy that's focused on client, patient-centered care and engaging the individual in their care planning process, and really a shift in many ways in philosophy about how we approach the care of seniors and individuals with complex needs. It is a strategy that involves all sectors in healthcare. So it's not just about what happens in the hospital, but it's about those support services in the community and those transitions from hospital to home. And so we find a role for most of our healthcare providers in this strategy. And each LHIN, to support the Access to Care initiative, has identified a number of key initiatives at a provincial level and then locally that tie into the Access to Care agenda. So we think it's important for a number of reasons, and central to that is really the patient or client experience. We know that we have significant flow issues across the healthcare system as it relates to supporting people to move from acute care back to home. We continue to see high volumes of alternative level of care days within our hospitals, and in particular areas within our LHIN, which we'll talk more about shortly. And that really does impact on access to hospital-based services as well. So if we can't move people out of the system, it blocks people entering into the system, as you know. And so those long ALC days really do negatively impact access overall, but also from a patient care perspective. And really at the heart of this, we know that when seniors stay longer in hospital, it's a risk to them, to their health. We see a decompensation of seniors, greater incidence of delirium, infection rates, etc. So those are all things that we're trying to avoid, as you know, when we're caring for our senior population. And so trying to shorten that length of stay and support people to appropriately move back to home is really what this is all about. And trying to minimize the people that are getting put on that long-term care home wait list. And so part of this is a recognition that the processes around long-term care home placement are really a social process. It's really understanding what supports are there for that individual. And the best time to make those decisions around long-term care placement are probably not when somebody's experiencing an acute care episode. They're at their most frail, their most fragile. And so the decisions that often get made at that time may ultimately not be the best decision or the right decision in terms of where that individual could be supported into the future. So this slide, I'm not sure if you can see it very well, it looks a little faded where I'm looking at it from, but this represents a number of those key initiatives that have been linked together under the Access to Care strategy provincially. So this ties back to the Excellent Care for All legislation and the focus on quality improvement, and again we talked about that at our last engagement session with you. Focus on senior-friendly hospitals, so you may be aware that all hospitals in Ontario responded to a senior-friendly audit a number of months ago, and we're just now receiving, actually in the next couple of weeks, we should receive the provincial summary of that audit that was done across all hospitals. We've seen our local summary here in the Southwest, and that will be available on our website. And that's really being used to identify some priorities for hospitals around senior-friendly care. There's a whole piece provincially around falls prevention and a toolkit and framework for how we increase our focus on falls prevention. Behavioral support services, so focusing on seniors with behavioral and mental health issues is another key area of focus. So I won't go through all of these, but at a provincial level there's work happening with respect to each of these buckets, and then at a local level as well, tying that work together to again focus on access to care and that seniors population. And as well, some of you may be familiar with the report that was released by Dr. David Walker. He is the provincial ALC lead, and there were over 30 recommendations in his report, many reaffirming work that's already happened in the province related to alternate level of care, but really emphasizing again that message around the fact that the healthcare system has historically and does continue to rely too heavily on permanent placement options for seniors, without consideration to what that patient's potential is for rehabilitation and the ability to improve and recover and be supported at home. So again, tonight is a lot about that principle and how do we really support seniors philosophically to get the best care and the best outcomes and remain at home as long as possible. So I'm going to turn it back to Bob to introduce our video and next steps.
Thank you, Kelly. We're going to show a short video on access to care and home first. And then following that, Donna Ladouceur and Kelly are going to come up and they're going to speak in a little bit more detail about home first and access to care. I'd like to introduce Donna before the video. Donna is the Senior Director of Client Services with the Southwest Community Care Access Centre. Donna is accountable for operational implementation of Home First for all hospital sites. Donna has over 20 years experience in the community and has a passion for enabling a positive experience for patients and caregivers at the transition points in our system. She has lived her personal experience and she knows how perfect it can be, and she also knows how devastating it can be when it does not work. So we'll invite Donna and Kelly up after the video.
So again, we just really want to provide that additional context, but really we want to ultimately engage you, so which is why we're going to rush this part of the evening so that we can get to the small group discussions and the dialogue with you and the expert panel that we've brought together for this evening. So you've heard a little bit about this again, and really relating to the risk of seniors in hospital and the risks associated with hospitalization and the potential decline of seniors while in hospital, and really trying to make that shift again to a home first philosophy to support seniors. And this really does relate to some of the system challenges that we see. In the Southwest specifically, we have a target of 8.8% in terms of our ALC days, and we are consistently above that target, ranging anywhere from about 9.5 to over 15%. And we know who our greatest contributors are, and you'll see some data slides in this presentation that show us our ALC hotspots, as we call them, one of which is Owen Sound. And also, a lot of this, when we look at things from a process perspective, we know that referrals to CCAC, 50 to 90% of those are happening on the same day of discharge. And so when you're ready to discharge and trying to get a care plan in place, if that connection is only happening on the day of discharge, it does not make for a smooth transition. Also, we know that people are being designated alternative level of care before the CCAC is involved in that discussion, and once that road to long-term care has been identified as a potential for families and patients, trying to reverse that or change that outcome is really difficult. So a lot of this, again, is about delaying that decision around placement, bringing the person home, and then putting a care plan in place. If that is long-term care, then that's the plan that gets put in place, but if there's other supports, then that's what's emphasized. And some of the work that's been done most recently in the LHIN, looking at long-stay ALC, has really highlighted the need for better processes around discharge planning for those ALC clients. I think a key for you this evening is thinking about why is access to care important to you. So you may find that services are changing, or there's additional capacity in the community to support your patients going forward. We may see patients moving more quickly, ideally, through the acute care phase and treatment, so that they are returned home and supported in home more quickly. You may be asked, as this rolls out across the LHIN, to be involved in implementation, and so hopefully if you are tapped and asked to be on an implementation planning group, you're able to be part of that process. You may see changes happening and experiencing those in the hospital as it relates to discharge planning and how clients flow, and importantly, you may be asked to change your approach to how you care for seniors. And so a lot of the conversation that we had at the London-based engagement session was really around how does this impact physicians, what does it mean for care, and your ability to rely on the other parts of the healthcare system to benefit your patients. And a key part of this process change is also looking at information technology as an enabler, and so there's a whole stream of work looking at how we better use technology, build on some of the examples out there. So this diagram really just talks about what do we want to see from a flow perspective, earlier identification of high-risk seniors in the community, more proactive engagement with CCAC to support discharge planning, so those things that we've talked about. And then this slide starts to line up all the work that's already been happening in the LHIN that relates to supporting flow. And there are a number of initiatives. So although we talk about access to care as something new, it's really a culmination of a lot of work that's already been happening in the LHIN. And so each of the bullets in the bottom half here are different initiatives that link back to what's happening here in the Southwest and in many instances across the province. Now, some data slides we thought we'd share with you tonight. So this slide is looking at the trend in percentage ALC days across our LHIN broken down by geography. So you can see that the top line is actually the north, the Grey Bruce area. So you can see that your trend to the end of the fourth quarter in 2010 has certainly been upwards. This is looking at those in hospital waiting for long-term care, again by geography, the percent of clients from November 2010 to September 2011. Again, Grey Bruce is the purple line, so you can see there was a good dip, and then we've been going up again, so something to be mindful of. This slide actually tracks the ALC clients waiting for long-term care placement against some of the Community Care Access Center interventions, specifically looking at the personal support service hours. And so as you might expect to see, as additional hours were being provided, we started to see a decline in the ALC wait list. There was actually a point where some services had to be paused, and you can start to see that the ALC numbers going up again, and the personal support services went down. And so we're trying to get to an even keel on that going forward. These slides we refer to as our bubble diagram, and I mentioned earlier our hotspots within the LHIN. So when we look at our percentage ALC days, by and large, LHSC dwarfs the rest of the LHIN in terms of its contribution to our ALC challenges, and hence why we started our Home First implementation in London. If we take London out of the equation, then you can see the bubbles that rise to the top, and actually it helps us to identify our next wave of hospitals for implementation. So our focus is on Woodstock, St. Thomas Elgin General Hospital, Tillsonburg, and Owen Sound as the next greatest contributors to the ALC challenges. This slide is looking at number of ALC discharges and number of cases designated ALC within 2 days of admission. And this is considered an important marker across the province. And if you remember that circle diagram at the beginning around the provincial initiatives, 2-day ALC was one of those initiatives. And so there was a deep dive into that data looking at the percentage of clients designated ALC within 2 days, with the thinking being if you're admitted to hospital and you're already ALC within 1 or 2 days, did you really need to be admitted in the first place? A group of that population is often looked at as social admissions that have come into the hospital for circumstances that not really a necessarily significant medical need, but more the social circumstances, and you're designated ALC quite immediately within the hospital. We have an interesting piece of our data to do more follow-up on. So in Q2 of this year, so the last quarter that we've just passed through it to the end of September, we're seeing our ALC discharges dropping. So that signals that we're not moving people out of the hospitals to the same level that we have been in the past. And interestingly, a greater proportion of them are 2-day ALCs. So some definite follow-up work around the data in this slide. And then this is a busy slide, but what it's looking at is the percent of same-day referrals to the CCAC. So again, percent of cases that are referred on the day of admission or discharge rather, to the CCAC. And you can see that there's a number of high spikes, so again, anywhere from 50 to 90% of discharges are being referred to CCAC on the same day. So this is certainly from a process perspective, something we want to see decreasing into the future. And then this is what we call our long stay ALCs, so clients that are waiting over 40 days by geography. And again, you can see that top line, that's actually the south. The north you can see is the green line, and when we did our first long stay ALC review across the LHIN with the support of the CCAC, that work was done in Grey Bruce back in March. And if you look, you can see that sort of in the May, June, July, there was a good drop in the long stay ALC clients here. Now we're starting to see those numbers go up again, but there was some really good work done, partnering between the CCAC and the local hospital around those long stay ALC, and other providers too coming together to see what kind of care packages could be put in place for those individuals that have been in the hospital for a long length of time. So we learned at that time as well that needs to be a reoccurring process, that we need to consistently and constantly be looking at those long stay patients that are in your hospitals. And then just the final slide from a data perspective that I wanted to share. This is our long-term care demand and supply in the Southwest. So oftentimes there's a concern expressed that we just need more long-term care home beds. And although that may be the case in some areas of our LHIN, and we definitely may not have it lined up perfectly from a distribution perspective in terms of where those beds are, and that's very hard to change given how long-term care is operated. By and large, we are higher than the provincial average in terms of beds per population 75 and over. And so although we might think we need more long-term care home beds here in the Southwest, we are very unlikely to see any new long-term care home beds coming into our LHIN. There's actually some shifting of long-term care home beds now through what's called the B&C redevelopment process, and so we're mindful of some of those changes. You may be aware of some of those that are impacting communities in Grey Bruce as well. But the answer really isn't more long-term care home beds. So we really do need to figure out how to reduce the long-term care home wait list and make sure the right people are accessing those beds, and that other programs and supports are in place for people that can be sustained in the community. So I'm going to just turn it over to Donna, and she's going to talk a bit more about what it's been looking like on the ground with access to care implementation.
Thanks, Kelly. Because for me, it really is, what's the impact for the system? What's the impact for you as physicians in the community and in the hospitals? But as well as for Home First, it really is, what's it mean on the ground for our patients and their families? And for us, it's really to have a more integrated and a more proactive approach to discharge for patients from hospital. And Kelly talked a lot, and you heard in the video, around that last-minute discharge planning. We have to be more proactive with these folks. So we have to be able to identify who these patients are that are at risk to be complicated discharges who may have difficulty returning home. And we need to do that quickly. We need to do that within 24 to 48 hours of admission to the hospital. And we need to be able to have CCAC increase our ability to do system navigation for these clients and be able to connect people up with the right level of care in the community. So we are looking at a phased implementation, and as you saw, we did start in the south. We did start with the university campus of LHSC because of the volume of their ALC clients. But because we launched there, it doesn't mean that that's the only place that work is happening. There's a significant amount of work happening here in the Grey Bruce area, and I would say that's around a readiness to adopt a home-first approach. There's been significant work happening around an integrated discharge planning model, as well as a real collaborative approach about looking at these patients and returning them to the community. So what's different? I mean, I know that people will probably say, so what? Well, how's CCAC going to support these people differently at home, and how are we going to be able to meet the demands? So we need to build on some of the initiatives we've had. We've had some programs such as Safe at Home, Wait at Home, programs that enhance the level of supports that are available for people to be able to be maintained and sustained at home. Kelly talked earlier of our increased maximum levels for a personal support worker at home. But we also need to be able to change our staffing model to be able to support these patients. So we need to have intensive case managers in the hospital that can be responsive. So when a patient is identified, that we can be there and be present with them and their families to be able to start this process to return them home. But we also have to have that catcher's mitt out in the community. Because if you're going to take that leap of faith and trust that we're going to be able to meet these demands in the community, we need to be able to step up to the plate to do that. So we need to alter our way of delivering case management out in the community for these very high-risk, vulnerable clients. So the case manager has to be able to get out quickly once the patient's at home. And we also have to have the right level of service provision for these clients at home. So we have to alter the way we have our service providers set up to provide the service. Around the assisted living, supportive housing, and adult day program, what changes are going to be talked about when we talk about this stream of access to care? What we need to do is we need to look at the capacity of these programs, and we need to have it distributed equitably across the Southwest. And one way of looking at, are we ensuring that we're getting the right people into these precious resources, is to have a centralized point of access so that we have consistent criteria. So we've got the right people utilizing those programs at the right time. So that will be part as we roll out and transition that. And there's going to be some exciting work happening actually in the Grey Bruce area with some of the ADP programs around looking at the opportunity to have a different way of supporting some of our more complex clients with adult day programs. So we need to make sure that we have a mechanism that's flexible and responsive to be able to support these clients. The implementation and planning are predominantly happening now with the implementation in 2012 and 13, but there will be some pilot sites starting before that. Rehab and CCC beds, what's going to happen there? What's the change that's going to happen? Again, it's around that equitable access for those beds and the distribution of those beds. So we need to look at across the Southwest. As you well know, in the Grey Bruce area, you don't have any CCC beds. We need to examine where should these beds be located to be able to support the residents of the Southwest. Again, it will be coming up with and defining common entry criteria for these people and a single point of access as well for these types of beds. Again, the implementation is happening through this fiscal and next, and we will be launching our first site in the Woodstock area. The other thing that is a key for all of this, and as we look at where patient transitions run into difficulty, it is often in the delivery and the communication. So often your patients for primary care arrive in a hospital. You have a wealth of information about those patients as what's happening to them, what you've been working with them. They go into hospital, there's not a way to transition that information. So they come in and people spend lots of time, you know, doing a history with them, but there has to be a better methodology that we have an IT enabler to be able to make sure that information is connected in. Also, we need an automatic referral. There are flags. There are key identifiers for patients when they present in a hospital emergency department that would indicate that discharge is going to be a difficult thing for these people. So let's make the referral right away, automatically, to CCAC so we can get involved with them. Because what happens at times is a family comes into the emergency department, they're distraught, they're overburdened, they have the suitcase packed for mom or dad because they don't know how they're going to cope any longer. So they come in and somebody says, well, gee, it must be time now to go to a long-term care home. As soon as those words are out of somebody's mouth, the family goes, okay, my job's done, I can go back home. The person goes, well, I guess that's where I'm headed, it's to long-term care. So we need a mechanism to be able to have the conversation with them about, let's get you back home, and then we can talk about what's the right supports for you. We also need a better methodology to be able to do some medication reconciliation for our patients. In some of the emergency rooms, 30% of patient visits are around medication reconciliation issues. How good would it be if we actually could have a medication summary go out to primary care, out to CCAC when a patient leaves the hospital, so that you can understand what changes have been made. The same around a discharge summary. How can we have a methodology to enable discharge summaries to get to the primary care team as soon as possible so they can understand and support what's been happening in the hospital? So there's significant work that's being looked at as part of the e-health stream as part of this whole Home First and access to care to enable better communication and dialogue. So the first patient story is really the first client that we had go out of university campus for our Home First. And this was a patient that I would say 6 months ago, hospital teams and probably CCAC team might have looked at and went, no, they're going to long-term care. There's just absolutely no way about this. The client had been on CCAC services prior to admission to hospital, but was in an acute exasperation and had multiple comorbidities. While they were in hospital, we were really concerned that if this patient remained in hospital for too long a period of time, they were going to become very, very deconditioned and we were not going to be able to return them to the community. So we had several conferences with the family and the whole care team, including the allied health. We also involved the primary care team to talk about what would it take and what would need to happen for us to be able to transition this person back home. So we were able to transition the patient back home with what we called enhanced supports for the first 4 weeks that they were home. So it would be a service level above and beyond what you'd anticipate from CCAC. And this patient has been able to remain at home. She was supported for the first 4 weeks on the plan, but that now has actually transitioned off our supports as a CCAC and is being supported by Supports for Daily Living program. So she really is going to be able to be maintained at home, and it looks like she's not going to have to go to long-term care. And otherwise, without the benefit of this program, this is exactly where this woman would have landed. So Kelly, do you want to talk about the performance metrics?
Thanks, Donna. And just to emphasize the piece around, I shouldn't say inappropriate, because at the time it's probably appropriate admission to long-term care homes, but we see a number of examples in the LHIN where people have been admitted to long-term care, and once they have better nutrition, the constant care and support from the long-term care home, they do rebound, and then they're at a point where they probably could be supported at home, but the house has been sold. There's no way to transition them back to home after that point. So again, it really emphasizes the rationale around trying to get people home before decisions are made around placement. From a metrics point of view, this is work, as I said, that's happening across the province, and we have the benefit of a number of LHINs that have implemented Home First, and through that process, provincial metrics were actually defined. So these are just a sample of some of those measures. So we are actively tracking and monitoring our percentage of ALC days, our ALC to long-term care home days, percentage change in the numbers on our long-term care home wait list, the change in outcome measurement scales from the InterRise suite of tools. So again, that's looking more at the client acuity and looking for those higher level acuity clients to be supported in community going forward. And then a really easy process measure to be keeping tabs on is the number of long-term care applications initiated in hospital. At the last session, I made the bold statement it should go down to 0. It's probably unrealistic. There will always be some admissions being done from hospital, but we really want to see that number being reduced in the spirit of the Home First philosophy. So this is really now moving into the most important part of the evening, and that's hearing your questions and comments about Home First. Happy to just take a couple of minutes if there's any sort of burning questions of clarification that you have, but then we are going to move into a break, and then after the break we're going to ask you to discuss these questions at your table. And again, what we're trying to get to after about a half hour of your conversation is an opportunity for you to engage with our panel members this evening that are going to respond to any of the questions or concerns or issues that you flag around access to care and Home First implementation. So I'll just pause. Are there any questions that you have right now around any of the information that you've heard so far that you want to voice before the break? Yeah.
I'm just wondering if we could get a little bit more clarification about what the enhanced community care support is. Because, 2 hours a day isn't going to work, and, like, what does that mean?
So for many of these patients, it's sort of for the first 2 to 4 weeks they're home, and what it is, it's up to 8 hours a day that we were actually supporting them with. And what we look at is it's not just their activities of daily living, we also provide support around some housekeeping and some meals during that first 4 weeks. Because what we found in another piece of work that we did called the high-risk seniors is many of these people, if they go home with that enhanced level for 2 to 4 weeks, their functionality does increase when they get home, and we're actually able to return them back to a more normal level of support. There will some that are going to need, of course, more than 2 hours a day, but it is an enhanced for that bridge time when they first get home.
So who looks after them through the night? Does that, I guess when you say the right care for the right person, my question would be by the right people. Because I have this huge fear that this is going to just fall back on already stressed middle-aged people who are trying to look after their teens and their kids and sleep over at mom's house because she got out of the hospital and she's kind of confused at night. And, I think something like this needs to happen, but I do worry about the after hours, the nighttime.
So some families do choose to use the support overnight, right? They can. They don't have to have it during the day. They can have support overnight.
Sometimes they need it a lot more.
Right. So what we look at, if it's 24 hours a day care, we have sent 3 people home on 24-hour a day care to see if we're going to be able to maintain them at home. But what we do know is for some of these people, they're still going to go to long-term care, because we don't have a system today that can support 24-hour a day in-home coverage. But at least we get them home, we make that decision with the family and the client and say, there are not enough system supports to maintain you at home, so now we are going to go on a list for long-term care, but it's better for them to wait for admission for their long-term care home, at least out of the community at home, instead of in a hospital. But some of them we will not be able to sustain at home, we know that.
And when you think about the wait times to get into a nursing home, I just can see, these poor families, yeah, we got them out of the hospital, but, we've had extra help for a few weeks, but now we're waiting for a nursing home bed, which there isn't in, we don't have. And, some poor woman is trying to work and is going to end up staying at mom's house overnight for weeks and trying to, it's just, it's a huge responsibility for family. And I think, 40, 50 years ago, we all did that, but now it's just such a busier world.
You're right. And the other thing we do with these folks, if it looks like at the end of the day the only right place for them to be is in a long-term care, we do what we call right now, they go on a more higher priority wait list, because we know that the family, they've done this in a leap of faith, right, to see if we could support them to try and move them to a long-term care facility sooner if we can.
So I think it makes sense to move into the break. So again, just to give you a sense of what you're going to be doing at your tables when we reconvene at about 8:05, it's to have a conversation about these questions. There's templates on your table, and we'd appreciate if you have somebody record your discussion, because we want to take away the points that you make this evening, as well as preparing any questions or issues that you want to flag for the panel. So we're going to take about, I think it ends up being more of a 10 to 12 minute break, reconvene about 5 after 8. You'll have about a half an hour at your tables for discussion, and then we'll move into a broader conversation and talk a bit more about some of the issues like the one that was just raised.
Approach to patients who are generally going to fall under the umbrella of complex continuing care at some point, which is difficult to predict, but you know some of the patients that
come out of the
ICU, and I'm just wondering what we should do differently, more or less.
Well, I guess number one is the message we're hearing here is if we can flag them early, and I don't know how hard it is from the ICU perspective to identify early on someone who's going to need a lot of services, you know, above and beyond the ICU. And I think another one is that, you know, we stop duplicating the work that is done in the ICU by nursing staff to assess them and what kind of services they may need, and then we have to do it all over again when they come out to the medical floor. If we can streamline that in a better way.
So should I be checking off CCAC referral the day someone is admitted to an intensive care unit bed?
Well, again, that's part of the message we're hearing. Yeah, the earlier we can do that, the faster or better prepared we are to deliver those services.
So what happens after I do that? Because I have, and I've never seen it.
So a case manager should, so in an ideal world, and I'm sure there's times that we do it and times that we don't, but in an ideal world, a case manager should make the connection, come up, you know, to the staff, whoever's made the referral, right? And then make a connection with the family as well. So the family are prepared that the eventual spot is going to be, you know, either back home or, but to start that conversation. Because what happens is we've found and we've looked at, and I think I had some conversations with Sue, is sometimes that journey in the intensive care unit isn't a long journey. So what happens if if we're never connected, then they get out to the floor and they end up going home rather quickly. If we're not involved, it's all of a shock to the family. So make it as early as possible, and we'll get the staff aligned that they need to make that connection in. Even if it's just to touch base with the family and the physician referring, to know that the plan is still to return them home.
Yes.
So we had a lot of questions around the after hours, you know, weekends, that kind of thing, access. So just a concern, just your thoughts on what we do.
So you mean support from CCAC, like, but from all kinds of support? Well,
Community support.
So our service providers, our PSWs, our nurses, therapists are available 24 hours a day, 7 days a week. So we have an emergency response for the nurses to come out, our nurse practitioners as well. And PSWs, we schedule in for extended periods of time. What we have found, I would say, the benefit of the Home First program in the London area, what we've started with to get a feel for this is we have a dedicated service provider that has staff on standby for this period of time, for those 2 to 4 weeks. So that's a real enabler that we've done for Home First that we'll have to do as we move throughout. So they have staff ready and willing and able to go out, especially on after hours.
And with referral to drugs, so if they don't have access to a pharmacy after hours, those kind of things, your solutions for this kind of thing?
Well, I mean, I can't say for every community, but I believe most communities have a 24-hour drug access.
Not here.
For prescriptions.
Not
you wouldn't
here.
have here?
In Owen Sound, yes, but in Tobermory,
So if somebody were discharged from hospital, say...
No, you're right. What you don't. Not even in Owen Sound, sorry. Used to.
So where would patients get their drugs?
The patient usually gets sent home with, the patient will be sent home with enough pills to apply to most.
Okay, so you'll ensure that they have
That's
enough.
what happens now.
Okay, all right, so there's the answer. So patients go home with a supply from the hospital until such time they can get to their local pharmacy.
You shouldn't charge them.
But if I can just give a little tag on an answer here, I think you know, we are getting better at supplying services in those after-hour times and weekend times. But a key issue that came up at our table in discussion is don't promise what you can't deliver.
Right.
And that's where the whole system will fall apart.
And that's why in London, when we did the Home First, we knew that to be able to have the trust of families and our system partners, if we can't deliver, the first time we're not there when the patient goes home, it falls apart. So that's why we went to a model where we had to have a dedicated service provider with staff available to meet those needs. Because you're right, people will lose.
So Donna, when you're ramping up for here, the intent would be you're not going to try to say that you're able to offer that level of service until you've got enough manpower to be able to do that.
Yeah.
Go here and then here.
How is it proposed that the intensity of that early home first care provision is going to be even feasible outside of an urban center? We've got people who go home to their very small place, 50 miles from any place that has a measurable population in the middle of the winter.
You're right. I mean, that is a challenge for us, I would
So,
say.
but the question stands, how do you propose to actually put that in place?
Right now, it's the same as we have with our current PSWs. What we have to have is a backup. Anytime we send a patient home that's at high risk, that is in a geography that we know could be hampered by winter weather, by having somebody in the home, let's say, we have to have a backup plan in place. Because if I have a PSW that's traveling out even 20 kilometers to somebody's home, if I can't leave that client unattended, so we always have to have a backup plan in place for those people. We can't just rely on that single PSW. And that's the reality of somebody in their home.
Paul, we got the funding from the LHIN to support our pilot restorative care unit project, and so that's going into Owen Sound and Justly. And we're hoping that that unit can be a huge boost to what we're trying to do here by saying, okay, we're taking you off the medical unit, we're taking you out of the small number of beds we may have at one of our rural hospitals, allowing you to be in that restorative care unit for 30 days and working to increase your level of functionality so that you actually can go home, CCAC can get ready to accept you, you understand a little bit more about your medication, you're able to do more of those activities of daily living. We were just talking at the table about it's such a hard thing for family members to fathom that being in hospital might actually result in you declining. You know, of course mom's getting better. She's in the hospital and she's safe, so I don't need to worry about it any longer. And I think to be able to shift them out of that acute care environment where we're pushing a 4-day length of stay or 3.5, you know, 3.5-day length of stay to say, okay, you can have some more days here. CCAC be involved right away to say the goal here is to have you go home. And in London where they've done it, 60% of those patients are going home. Many of them would have gone to alternate level or would have gone to long-term care before. So not even flagging them as alternate level of care, just putting them in the unit, having them have that stay and hopefully be much more successful when they go out. So that's the pilot we're about to launch and just.
And it's a tough go in rural communities. Even, I mean, we have, you know, I look at even down in sort of the London catchment area where we're starting. I look at some of the rural areas down around Port Stanley, down in Port Rowan. I mean, they're isolated, you know, winter weather comes. So that's why we have to be really careful. Sometimes patients want to go home, but they're all alone. And if that PSW, for whatever reason, can't get there, then we have to think, you know, what kind of risk are we putting them at? So, I mean, it is a challenge in the rural communities.
I think there was a question from this table.
To echo a little bit what Paul said, I mean, I'm a family physician and I don't see the CCAC has nearly enough resources and staffing to support what you're proposing at the moment. And when I look into the next 10 years of healthcare, I don't see CCAC budget going up incrementally each year enough to support that. And I'm wondering how you propose that you can support the budgetary requirements of that increased intensity and staffing in a rural community.
I think what's going to happen, I mean, if you look at where our funders, I mean, where the ministry is focusing, this is on the complex clients, the most complex to keep them at home out of hospital. But then how are we going to support the less complex, right? There's going to have to be other supports within the system that isn't just relying on CCAC. If we're going to focus on being able to support people to remain at home, what other system supports can we, for those other folks, like adult day programs? The people that can go out of the home to get supports versus the people that remain in the home. But you're right, it's going to be a challenge. There's no way about it.
I mean, the LHIN to the south, so like we have Dundalk in our area who's in a separate LHIN.
Yeah.
Every year you see services cut. I mean, we send patients to that, to send a patient to that LHIN is much harder than to keep them in, if they're within this LHIN, because the services are even less.
Right.
And they won't come and see them, and they won't support them. And they're probably under more budgetary pressure than we are at the moment.
Mm-hmm.
And that's why, looking forward, I see, well, I don't know how easy this is going to be.
It's going to be a challenge as we go. I mean, looking at the volume, even looking at the first 10 people that we have on the Home First program, they're complex people, right? They're going to need sustained support. So you're right, it's going to be a challenge. We're going to have to face that.
And your long-term care wait time is a hell of a lot more than 4 weeks. At the end of that 4 weeks, you've decided, no, it's not going to work. I mean, I do think that there's a window of opportunity there.
Right.
There's a group of people that if we can get them early,
Yeah.
that we could potentially give them more time at home.
Yes.
But there's going to be a significant number of people who reach the end of the 4 weeks who go, oh, nope, this ain't working. And the traditional method is then drive them to the rural emerge, where they get admitted. Or they go to Owen Sound emerge and get sent to the rural emerge.
What we are doing with these folks on the Home First program is we are putting them, they have a different priority status. So at the end of the 4 weeks, if it's clear we can't sustain them in any way at home, we put them as a different priority status. And I will tell you, they are getting placed quicker than the rest, because the answer isn't to ship them back into your hospital. Right?
What's the wait time for that then?
On average, across the Southwest, if they are a priority, they'll be in within 4 weeks.
So is this, do they move over to what's called a Wait at Home program? Which is one of the things that we're using here now.
Yes, and you are the biggest user of Wait at Home is in the Grey Bruce area.
Because I know.
And it's worked really well. And I mean, I know some people will say, well, you're just, creating these patients, but at least we're getting them out of the hospital and they can wait at home for their bed, but we have to change their priority.
There was a hand over here, and I'll come right back to you, sir.
The one question you have is, are there new tools developed that will help practitioners identify earlier the high-risk seniors in the community? So just even as while they're already emerged, is there some sort of a scoring tool that can be used or have been used per se to identify these patients with high risk and potentially end up staying in hospital longer? And even for primary care practitioners, can we use those risks already, those tools already in while they're outpatients, and identify them quickly as, yes, they are high risk, so heads up, maybe we can get CCAC involved by the way, or...
I think that's a really good question, and I know as part of the Partnerships for Health work, where case managers were more closely aligned with some of the family health teams, that was a great opportunity where case managers actually were part of sort of the rounds within the team. So if physicians or their staff were talking about these patients, the case manager might go, that person, like maybe we better get a referral now because there's some risk factors here. But we haven't developed a tool to use with primary care, but I think that should be an outcome of our Home First.
And I'm not aware of a tool either, and I'm not doing Emerge anymore, so Dr. Evie may want to comment. But I think some of the very hard informal ones are they a frequent flyer in Emerge? Yep. How many drugs on their drug list, and how many falls have they had in the last month, 6 months?
Yeah.
Those are the things you look at.
We're doing a falls risk screening tool in Wyerton, which we're about to roll out to all the hospitals, and certainly all of that tool is available for any of the family health team folks who'd be interested in it. And really strong evidence about risk of fall within 6 months of death, actually. So very high correlation. So if that's something any of the family health teams would be interested in using, we'd be happy to share it. Public health's involved in the initiative as well.
Another indicator is if families are starting or caregivers are starting to say they're getting burnt out, or I just can't handle this stress, we find that's really an indicator that, you know, we need to get some interventions in to give some respite to those family members.
I have another question. What happens if you refer a patient to CCAC for geriatric assessment, psychogeriatric assessment, and they refuse it?
CCACs refuse to do
No,
it?
CCAC.
Oh, the patient
They're there at the
refuse?
door and the patient refuses.
Are they
Initially, the
competent
patient
to
agrees
refuse?
it.
We don't know, nobody will assess them.
Then they get assessed. So then what? So then, right away, we know she kind of.
Yeah.
So then what? Is there some way beyond that?
So if you've made a referral for an assessment, but the patient refuses the assessment,
Initially, they accept. They say,
Right.
yes, it's a good
but
idea.
then we try and go in and
And they change it.
the only thing, if there's family involved, sometimes what we ask is we aren't going in to do that assessment. We'll go in to do just a general assessment, and sometimes patients will, if they don't think we're going in to do a psychogeriatric assessment, if we're going in just to assess the environment, to see if we can give you some extra support, sometimes they'll let us come in with that type of approach. It's a tough one when the patients refuse if they're confident.
This table's been waiting patiently.
With the advent of our trial here for restorative care, Kelly was saying that it's been identified that we don't have any complex continuing care beds in the area. So,
We have some of them, we have 5 of them. What's like a term?
For the region. Would the LHIN perhaps try to bring that identification of where some should be and how many should be at the same time as this restorative care effort, so that those people who fail the restorative care trial have another direction to go, because my concern is that those people that don't do well with our restorative care planning there isn't going to be any answer for those people, and they'll simply end up being readmitted to the acute care area of the hospital.
So as part of remember the stream that we talked about as part of the CCC and rehab beds? There is going to be a review of all the CCC beds that exist today across the Southwest, and looking at where are there opportunities. Does there need to be a realignment of those beds? Because when we did the ALC review, the long stay ALC review, we found that there were actually some folks in long-term care that are too complex for long-term care. They should be in a CCC bed, but you have none in this area. So as part of that stream, I think there will be an identification and hopefully an alignment of where do those beds need to happen and occur.
I have a second question, if it's okay.
Okay.
I just wondered if clearly there's some e-solutions that work really well in those transitional points for patients when they're moving from one situation to another. And does the LHIN plan to assist us more in the hospital system here to introduce those technologies and with some real dollars to support acquiring them and getting them off the ground?
Everyone's looking at me. Maybe just in response to the first question, if I can add to Donna's comments, there certainly is the stream of work around CCC beds, and there are 5 convalescent care beds, so different than complex continuing care beds here in Grey Bruce, just to clarify that. And one of the things we have identified through the implementation of the Restore program is the need to watch what impact the Restore program has on the convalescent beds. And so we really are looking at the system of care here in Grey Bruce with the Restore program coming on stream, potential impact of convalescent, and still then understanding what additional needs there might be for complex continuing care as it relates to that third stream of work. So just to sort of add to Donna's comments on that. And then as Donna described, from an e-health perspective, we do have a focus throughout access to care on e-health. We actually have a team of resources through KPMG that have been hired to do a access to care technology roadmap, if you will. So they're looking at what are those technology enablers needed in London, but also across the LHIN to enable Home First and as well as the other two streams within access to care. They'll be helping us to prioritize what those technology enablers are and look at what the implementation requirements are and actually help to support implementation of some of those. You know, do we have a pot of money to implement a whole slew of technology components at this point in time? No. But what we will be doing is looking at how do we strategize to work with partners to implement that. So some of those technology pieces are, you know, really part and parcel of what the CCAC and hospital need to do together. And some of them are, there's some, I think, easier solutions with the platforms that you already have in place. Others will be more complex and require greater investment. Some of those types of projects are things like resource matching and referral, which is actually a provincial project that Donna touched upon, and that really is moving out across the province. We're moving into the second phase here in LHIN to understand pathways, hospital to rehab, to CCC, to home, to long-term care, and how to understand what capacity is available within the system. Where are the resources to match clients to those needs? So some LHINs have already implemented resource matching and referral and have had amazing results coming out of that work, and particularly amazing data to then understand what's happening with respect to client flow within the system. So it is a very central piece of work within the access to care strategy.
Please, this came up my question.
Yeah, just regarding the same question that raised from the other table about the scoring system, came up in our table as well, and we were wondering whether there is any scoring system that we know how complex is the patient, and if we have all patients from a certain age, for example 60 and above, that primary care provider does the annual physical, if you have a tool that is prepared by health professionals and the primary health or care provider or family physician, they go through and they find out how complex is a patient in advance and renew it every year, maybe parallel with their annual physical at the same time or somewhere. So every patient, vulnerable patient, they carry a kind of number or a scoring system of how vulnerable they are if something happens. And then they get admitted in a hospital, so everybody knows what is the problem, and the patient lives in a remote area with no family support, many comorbidities. It's different than persons who live in a town with some people around. So, and it could be annually reviewed, so we ended up that kind of thing if you have.
It makes sense.
Yeah.
We don't, I mean, again, we sort of have, I think people have sort of these rough indicators, whether it's emergency rooms or it's frequent flyers, but I think it's something that could, I mean, we're developing it in the hospital for when they present, sort of, here's the 3 big flags of what means difficult discharge, but I think it is something that we need to think about as far as a system to be able to provide.
But, I mean, could they carry their resident assessment instrument score out into the community?
Sure they can.
Yeah.
Yeah.
And I'm not
Yeah.
familiar with the MAPLE.
The MAPLE is an indicator of functionality, right? And if you're at a MAPLE, it pulls information out of the RI and it gives you indicators. And so if you're a RI, a MAPLE 4 or 5, that means that you are pretty compromised in your functionality. And those really are the only people we should be seeing in long-term care. If anybody's less than that, they should be able to be supported at home.
So would you want those kind of scores to be sent out on the discharge summaries?
Yeah, if
we
we
could do
understand
that,
what
right?
is
Yeah.
and how we end up
Yeah.
to
Sure.
that score, that would be.
So I think we need to look at what are the key components you need when somebody's discharged from hospital. What needs to be included on that summary? And is it something like a RISE score or some type of score?
We were just talking at our table a little bit about some of the, I think the benefits are pretty obvious and it sounds great. Just in terms of some of the challenges, because it's basically the family doctors and doctors in the hospital that discharge that are needing to be really involved with this and streamlining a number of forms, faxes, emails, phone calls. A lot of my colleagues don't do home visits.
and refuse to do home visits, even in a palliative care situation. So there's going to be some resistance from some doctors just in terms of having to actually make a home visit, believe it or not. So just to be aware of that, just how do you make it easy, I guess, would be, and you can't answer that, but it's just a comment more, because most family doctors are, trying to do 1,000 other things too, as you know.
And we are trying, we are fortunate as a South West CCAC, we do have a lot of nurse practitioners spread across the Southwest, and we will likely be recruiting more to try and be able to support family physicians differently in the home.
Is that through a family health team, or?
No, these are nurse practitioners that are part of the CCAC team. They're called an advanced home care team. And again, we face recruiting challenges for nurse practitioners just like everybody else. Real easy to get in large urban areas as we start to spread out, tougher for us to get. But we are looking at how can they enable family practitioners to be able to support their patients differently at home.
I think we lost Dr. LHIN, but a few years ago, public health stole the idea from the drug companies about academic detailing, right? They would come into your office, buy you lunch, and spend half an hour to an hour telling you about, this is public health, but some new concept that they're pushing. I think you guys should think about that. A family health team opens up here in Owen Sound for the first Wednesday of the first month. Go in there, buy them lunch, and talk to them about your program. Go out to Southampton every Wednesday, or one Wednesday a month, and update a doc on their patients in the system.
And that was part of the whole Partnerships for Health project that went on for the past 3 years, and that was where we did have an alignment of a case manager, right, with a family health team, and we're just starting to look at how do we spread that to other family health teams. And that's exactly what the case manager did. She would go in, and there'd be a group of how many ever physicians, and they would say, well, I'm really worried about this person, and she could connect back with the case manager that might have been them and said, oh yeah, we've got them on the program. So it was that communication. We need to be able to figure out how to stretch our resources to be able to make that available, because it is that knowledge transfer that makes a difference.
She can't get there in person though. We use video.
Yeah, we use teleconference.
Question back there?
I was just wondering if there's a possibility of having better communication between the hospital and our family health team, because I have actually no idea until a few weeks after my patient had been discharged from the hospital that my patient was actually in hospital. So I was wondering, because we get it in a paper format that the patient was admitted, and it comes through the mail, so I have, unless, a blood result comes in and you're flagged, and you find out that, so just wondering, is it, within a day or two, is it possible for us to be notified that so-and-so has been admitted? Like, I know if I was sent the patient to referral to a specialist, I know they're in, so they're fine, so I know that we can expect, within several days the patient will be discharged, and we could then plan to have a follow-up appointment with us. Okay? But if the patient goes to emerge, we don't get the emerge notes until I don't know how many days later, and if they are admitted, I won't know for quite a while after that. So is it possible to strike up some communication system so that then I could say to the most responsible physician, these are my concerns about this patient, these are possible problems you might have as far as discharge, there's social issues, there's other issues.
Well, can I just take it, John, can you link in and get our notes right away?
Sometimes the stuff goes through, sometimes it doesn't. Okay, so when I head out to Salvo every week, I take whatever pile I've got that's meant for there, and that's done. If it arrives on a Wednesday and it's not been processed properly, then it probably may not be there until the week after.
Yeah. I was dictating all our discharges as staff, and medical records at first begged me, and then they demanded that I stop doing that. They claimed they would have them done within 2 days of dictation date, and they would be out to your clinics.
No, actually, I'm more thinking about on admission.
Yeah.
When
Well,
the patient comes in, is it possible to let us be aware?
Okay, and our admission note is a low priority note for medical records, so they don't dictate, or they don't type that one as rapidly as the discharge summary.
But that's what we've heard, I would say that's what I continue to hear from primary care physicians is you're a wealth of information. Your patients arrive at hospital and there's no really way right now in our system for you to be able to know your patients there, number one, or to actually be able to share the information with your hospital team about this. I mean, we don't have a mechanism right now to be able to do that well.
Well, we tried to do some, sorry.
The concern here is get the patient out of the hospital as quickly as possible to get in. So if I was at all able to add some information so that patient can actually be sent home sooner than later, I would say that this patient has these other sets of resources,
for her go to John.
then maybe
John gets them on his desk, and when he gets around to taking it to Saul, it goes to her file, and she gets
Maybe just to jump in, because this line of conversation happened at the LHIN event as well, and it's similar to what Donna's saying, that physicians have way more history and background on this patient that they've been caring for potentially years. And so the process that was talked about as part of it, implementing some of these home first changes was actually, if the case manager's linked in virtually at admission, then the case manager can help to play that linking back to the primary care physician. So actually could. So maybe your admission note isn't typed yet and in your system, but actually the case manager can help with that transition. And so they can be the person that hooks over to the primary care physician and actually helps bring that information forward as part of that proactive discharge planning that's starting earlier on in the process.
And at the same time, we would learn what the patient's baseline is, which is always the question.
Right.
Todd, we've got a lot of flags on our health records system now. Some of them trigger when you come into the emergency department. I'm not sure if there's one that we could trigger that would automatically send to Harvey, your patient was admitted, in Sound this afternoon.
Well, one of the issues, I think, that I was going to talk to Bob more about it and Emma after, but nurse practitioners don't exist right now in the intake form. So there's there's family doctor, but one solution might be to change that to primary care provider.
Yeah.
So that if it's a nurse practitioner, their name is flagged, because the patients may say Emma when they check in, but because officially they're registered or rostered to John Van Dorp, but his name isn't on the chart. So unless I actually know, like reading my note, that the patient was actually referred by Emma, and specifically ask a copy of the note to go to Emma, it won't go to her, and may end up not even going to John if he's not actually listed on the intake at central registration. So there's a potential way that notes can end up not going back to the primary care provider the way the system's set up to know it's out right now. And another issue might be for Emma and the nurse practitioners to, they go through the credentialing process and get a Cerner number, then they would be able to actually log in and check the, list of patients. And if they actually then, if you fix the one problem where they're actually registered and assigned as being the primary care provider, then they could go into Cerner each morning and they'll be able to see which patients their patients are actually in hospital. So I think there are some things that could be done to make it better for them.
We three from the South West Family Health Team were discussing this as we gathered from what Emma has said, and it seems among the three of us here, well, then that is it not possible for the medical records, for the admission officer to say who is your primary care provider, and this goes along with what Todd is saying, and just say, well, I'm a Lustig, or then both, or Roddy Caulfield, and could not the admissions officer fax? I thought of email, but it's not very confidential. Fax every day or at the time of admission that your patient has been a visit? or in some way communicate. And in that way, we could, I appreciate you say we could go into the Cerner system and check every morning what patients are being admitted. But I see how hard these nurse practitioners work. That's just one more task for them to do, as well as checking all the other things they check. Could the admissions officer not let family doctors and primary care providers know at the time of admission? Because so often, like we see, I get an ER record perhaps a week after the person has been to the ER, whether or not they were admitted, but it'll say family doctor, and it'll be Roddy Caulfield. Well, if they're admitted, could I not be notified that day, at that moment, by fax?
No, by who would?
Like I could see how we could then send a copy of our EMR with all of the medications, all of the personal problems, all of the past history, all of the ongoing problems, and fax them to the admitting physicians. And get a dialogue going and help to speed this home first syndrome. As Emma said, we usually don't know that our patient has been hospitalized until a week or two, or sometimes even 3, when the records start to come through.
I think a very easy system is implemented already. We use a EMR that anytime I admit a patient at night and I press 6 priority, early morning my admission note is there. And when I go to office and check my daily sheet, my first patient is my admission note there. So I have my admission note in my EMR when I first go to the office. And I assume anybody admit, like dictate the admission note in the system. And if it's my patient, and if I go to my office and open my EMR, the first thing that I see is my patient's admission note dictated in my system. So it's automatically there, and it's very easy system. I see in our system, when I dictate, I see my patient's note in my EMR the same day. But whether someone else admit my patient in a hospital and dictate, I haven't seen, because I'm pretty new in this area, but this is going on, and I see, and I think that's the best way to be done.
Yeah, just wanted to highlight for the group, so some of these exchanges of information we're talking about. So I think, Maureen, you were mentioning some of the flags in the system as well that are already there. Many of you have access to a Spire connection throughout the area here, and this is one of those connections that could be leveraged to start to transfer this information we're talking about at the time of admission. I think it's one of the key things that Donna and Kelly highlighted at the top of their IT enablers slide. That ED notification piece is what we're really all talking about right now.
Well, we started some of the early work with Spire here in Grey and Bruce. It was simpler to introducing in here than it maybe was in London. And so we're feeding you those test results already through Spire. So I'm not sure that there isn't some fairly simple way to feed you. Your patient got admitted yesterday. I mean, we're doing it to pick up patients who might be a readmission post a surgical admission. That's something we're doing across the 11 hospitals in Grey and Bruce. So if somebody presents from Kincardine who Todd just discharged 2 days ago, applied with peers, and he will be notified.
Never happened.
I think it is. Oh, never. Okay. So I think, you know, it's the same principle, so I'm not sure that the same thing couldn't be applied. Now, we may have to deal with the NP issue, just as Todd's saying, because it's that category doesn't allow for primary care provider, but maybe that's something that can be fairly easily modified. I wouldn't want to leave it up to somebody in patient registration to be faxing back to you. I mean, I'd rather have that automatically go to you and it pops up in your system and says, Donna Ladouceur, one of your patients was admitted yesterday at 3:45. So we can take that away and think about it. I think it would be very helpful, and as you say, then you can feed the hospital the information that you've got in the primary care setting.
I think we have time for one more question.
No question.
Maybe I could say, that would be great, and we do get the lab information through Aspire.
Yeah.
But we need to have our attention drawn to that patient. Among all the hundreds of patients we have rostered, we don't know which one is significant.
So just another comment, we were talking about system navigators, Donna. How can we expand that? How can we make it more accessible for some of the primary care here? The question is, how can we get somebody that watches them from time of admission, exit back to community and what's out there?
Well, and that's what we're trying to do with our realigning our model within the hospital, is that intensive case manager is follows them from the time they arrive till the time they go out, and then makes the connection back to that intensive case manager in the community, and follows the patient regardless where they are in the hospital. So if I start my journey and emerge and I end up in ICU, the same case manager follows them so that we don't have to have all those handoffs.
Okay. I'd like to, why don't we draw this part of the evening to a close. I would like to thank the panelists, and most of all, I'd like to thank the group. I think we had some excellent discussion tonight. We raised some excellent points, and we have lots of notes to take back and consider as a LHIN. So at this point, I'd like to ask Kelly Gillis to come back up for some closing remarks.
Thanks, Bob, and I'm going to end the night where I should have began, which was to express our CEO, Michael Barrett's regrets in not being able to be here this evening. He very much wanted to attend this session and had a event with the 14 LHINs that ended up being arranged. So I was his stand-in, so if it seemed like you saw a little bit too much of me, and when it was done in London, there was Mike and then there was me. So tonight it was just me. So anyways, Mike would have liked to have been here, and I think he'll be very pleased to hear the conversation that unfolded here again this evening. Very helpful comments and discussion. We hope you found it valuable to hear about some of these major shifts that we're trying to make in our healthcare system, and we have a lot of learning under our belt as a LHIN with some of the programs and initiatives that we've been able to advance so far, and your comments tonight will help us move those forward even further. Some of the pieces as the dialogue unfolded that I just want to highlight and I guess mention, we are really doing this in a phased approach. So we are starting in London. It has our highest number of ALC days and tends to be a bottleneck in the system. And we want to learn from that and roll it out across the LHIN. And we are monitoring closely. So actually Bob and I were talking about the fact that we're actually receiving weekly data to monitor Home First. And that's a lot of that is because of the things you've highlighted tonight. We need to know that the services and the supports are going to be in place. The minute they're not there, the system falls apart, the program falls apart, and the confidence in our ability to do this work is eroded. So we're monitoring the work of the CCAC very closely in this, looking at how quickly people are being pulled and supported to come out of hospital, how the bridge program is working. And so those are all things we're paying very close attention to as the London implementation unfolds, and then we'll be moving that out across the LHIN. So the Grey Bruce area isn't actually identified for full implementation until probably early next fiscal year, hopefully early next fiscal year. And so some of the components we did talk about tonight, so the bridge program as an example, that's not here now, but the intent will be as we move to our next set of hospitals, that service will be put in place. We're actually moving earlier than originally planned to St. Thomas Elgin General Hospital in the next number of weeks, and so within this fiscal year, and then we'll move out to Owen Sound, Tillsonburg, and Woodstock as our next areas of focus. So again, there'll be lots more on this, and a lot of what you started to talk about tonight leads us into the kind of work that needs to happen, and that's that process mapping, to understand how the business processes work, how communication flows, how to use your e-health enablers to flag those triggers to ensure the appropriate communication. Absolutely, the engagement of primary care up front in this process has been flagged, and again here tonight. So these are all the things that we need to take away from tonight's session and the other engagements that we're doing with physicians and other health service providers to ensure the best possible implementation of this program going forward. So again, really want to thank you for your input tonight. Certainly happy to continue the conversation. If you have questions or follow-up comments and you want to connect back with us at the LHIN or at the CCAC or with your hospital leadership, please do that. And we'd really like to continue this conversation. Again, on the issue of engagement of physicians, I mentioned the primary care network, and I think reaching out to primary care colleagues will be really key as this unfolds. I'd love to be able to come out and have lunch with each of you individually and talk about this, but we really have to think about ways to engage champions like of yourselves that have heard this and can help spread this to your colleagues. And I think physicians talking to physicians is always a good way to get the word out. So we need to do more of that as we move forward. So again, I really do want to thank you for your time commitment tonight. We know this is an add-on to an already full plate of things that you have to do. We are interested to get your feedback on the evaluation form, so please ensure that you complete that. And I'm sure now that you've stayed the whole evening, you won't forget to pick up your CME certificate on your way out the door. So thanks again for coming out. We'll look forward to being back up here again for our next session, but in between now and then, I'm sure we'll see some of you in different pieces of work that we're doing. And please, as I said, don't hesitate to connect back with us if you have other questions or comments about this. So thanks again. Have a safe drive home. Bye-bye.